Next candidate.
Doctor,
Yes,
can
sir.
you show
Hello.
us the hemorrhage in the previous case, please?
What?
The hemorrhage in the previous case.
Which hemorrhage? Just the
I
case
heard that there is a
before?
hemorrhage. Yeah,
No,
yeah.
no, no, no. No, no, I didn't tell any hemorrhage. I didn't talk
Oh, I'm
about any
sorry.
hemorrhage, doctor. Doctor, I said there are internal hernia. Internal hernia cause venous obstruction or compression and edema. And then if this case is neglected, it will be lead to arterial compression and ischemia. That is what I said. That is clear?
Yeah, clear. Thank you.
Okay, welcome. Next candidate.
Yes, sir.
Would you request control, please?
Okay.
This patient presented with a young patient, 5-year-old, 5-year-old child presented with a severe dyspnea. Go on.
Okay. So I'm presented with chest X-ray frontal projection of a child of 5 years of age, who
Mhm.
presented with dyspnea. On this examination, I can see that there is inhomogeneous opacification of the left hemithorax, and
Yes.
there is marked mediastinal shift towards the right side.
Okay.
Um, there is a rightward shift of trachea and heart as well.
Mhm.
In a patient of 5 years old age, I'm thinking
Mhm.
on the lines of foreign body aspiration, which is causing which is causing collapse. However, if it would
One
be a
second, doctor.
collapse, it would
Doctor,
be
one second.
epidural. Yes.
Could you think this is a collapse?
No, if it would be collapse, it would be have ipsilateral mediastinal shift, but it is causing contralateral mediastinal shift.
So,
It could be a large pleural effusion,
excellent.
um,
Or,
or any underlying mass lesion.
excellent. What will you do next?
Next, I will advise contrast enhanced CT thorax for further evaluation.
Excellent. Go on. Scroll, please.
All right. These are the axial sections, contrast
Okay.
enhanced in the
Okay.
mediastinal window. Here I can see
Mm-hmm.
that there is a large pleural effusion,
Mm-hmm.
and there is a heterogeneous mass lesion
Excellent.
seen occupying the left hemithorax, and there is also the rib erosion over here, irregularity of one of the
Brilliant.
rib of thoracic cage.
Yes.
So
Mhm.
in this age group, it could be a large blue cell tumor such as Ewing sarcoma
Excellent.
or
What
round
else?
blue cell tumor, which is
Excellent.
causing a large aggressive mass with
Mhm.
malignant pleural effusion and causing the marked contralateral
Excellent.
mediastinal shift.
Okay.
Um, I will like to see the lung window to look for the status of any pulmonary nodule in the contralateral lung
Okay. What else
for
will you
any
do?
metastatic pulmonary nodule. Otherwise, I will convey the findings to the referring clinician. This patient needs urgent MDT referral and urgent start of the treatment with after discussion, as it would need surgery plus chemo.
Okay. Thank you, doctor. In your opinion, what is the first line of treatment of Ewing sarcoma?
First line of treatment is chemotherapy in the case of
Excellent.
Ewing sarcoma, and
What is
after
the
that we can.
curative? What is the curative or what is the prognosis?
Prognosis is mostly good after chemo. There is some regression. Mostly they regress after chemo.
Okay. Do you know the percentage of curation?
No, sorry, I didn't know the percentage of
Okay.
curation.
Thank you, doctor, so much. It was a case of Ewing sarcoma. See here, my colleagues. Leave the mouse, please. Is a large left hemisthorax mass, okay, completely compresses the lung. See, the mass is enhanced here and associated with large amount of pleural effusion. The doctor made very well when she pick up the rib erosion. Where is the rib erosion? This one. This is the clue, okay? This is the clue. Okay. So she put a differential diagnosis of Ewing sarcoma at the top. Thank you, doctor, so much. Next candidate.
Hello, doctor. I'm here.
Hello.
Hello.
Yes, hello.
Assalamu alaikum.
Request. Salam. Request
I
control,
can
please.
hear you, sir.
Could you request control?
Sir. Okay, sir. I am
20-year-old
provided with
20-year-old male patient post motor car accident. Go on.
post-contrast CT scan images of 20-year-old male patient
Yes.
with history of accident.
Mhm.
First, I would like to scroll all the images.
Mhm.
Not scrolling. Visualized part of the chest uh, in the mediastinal window appears normal.
Mhm.
It's not scrolling properly. Visualized ribs as there is history of trauma. I'm looking for any fracture. No evidence of thoracic aorta injury is noted.
Are you
Esophagus
sure?
appears normal.
Doctor, once, are you sure?
Sir, I was suspicious at a point here. There is a nipple-like projection at the medial aspect of uh, arch of aorta. This with a flap. Intimal, I think so. There is a intimal flap.
So
Sir,
what's
it
your
is not.
diagnosis? Yes.
However,
What's
there is
your...
no evidence of hemomediastinum is noted. So
Okay, okay,
I'm
but
suspecting.
tell me about this finding, please.
I'm suspecting aortic dissection at this level.
Okay. What plane do you want?
So I want to see it on sagittal and coronal images. Yes, and there is indentation at the anterior aspect of the uh, thoracic aorta, arch of aorta, with a small nipple-like projection. No, I cannot appreciate any intimal flap through and through.
So what's your diagnosis? Hello?
Name, yes, I
Doctor,
can list. Yes,
what's
sir.
your diagnosis?
Sir,
Stop here.
coaptation.
Stop here.
Yes.
What is your diagnosis?
Sir, I'm suspecting incidental finding of coaptation at this level.
Doctor, did you remember the history?
Yes, sir. There is history of trauma.
So
So,
should you put incidental finding at the top?
firstly, I was suspecting dissection,
Okay.
but
What is your management or your next step?
I would. Sir, no, it's not coming in my mind. Sorry. The rest of the
Doctor,
bones appears normal. No, yes,
look, this patient
yes, sir.
looks like have a critical aortic injury. What is your next step?
Sir, I would urgently refer this patient in surgery for management of this dissection.
Okay. Then, could you have a look at the bones, please?
Yes, sir. I would, as there is history of trauma, I would like
Mhm.
to see the bones to rule out fractures.
Okay.
Visualize. Uh, there is no evidence of any rib fracture. Vertebrae are normal. No, I cannot appreciate any lumbar vertebral fracture. There is evidence of comminuted fracture involving the right iliac blade, with the posteriorly displaced fracture fragment. Yes. The multiple, yes, comminuted fracture involving right iliac blade with anterior displacement of anterior fracture fragment. It is there is also comminuted fracture of right acetabulum,
Mm-hmm.
increased joint space between at the level of right hip joint. I think so. There is evidence of soft tissue swelling as well as, yes, at this level.
Which syndrome this patient may develop?
Syndrome
Mm-hmm.
of aortic dissection patient.
No. According to the pelvis pathology, or in other words, what you are worried about may this patient develop later on. What is the complication of major pelvic bony fracture?
These can be associated with pelvic viscera's, for
What
example,
else?
bladder. If there is involvement of the large bone, there may be evidence of pulmonary embolism.
Excellent. So he may develop a fat embolism syndrome, including
Yes.
pulmonary embolism, skin embolism, and cerebral fat embolism. This is the syndrome. Thank you, doctor, so much. Here, my colleague, leave the mouse, please. Leave. Here, my colleague, isthmus injury, pseudo aneurysm. This is atypical. This is the isthmus, my colleague. You should tell the examiner this is an isthmic pseudo aneurysm because it is very characteristic. The isthmus is the junction between the distal part of the arch and descending aorta. And after examining all the bone, marked, severe, displaced, fragmented, or comminuted right iliac fracture. And see dislocation of the hip. This is besides the local injury of the pelvic organ, we are worried about fat embolism syndrome. Thank you so much, my colleague. Next candidate.
Assalamu alaikum, sir.
Alaikum salam. Post control, please.
Yes, sir, I requested.
Doctor, this patient has a knee pain. Go on.
Knee
I
pain.
think all the images are static. You
Okay.
can go through all the images.
Okay, sir. This is coronal view MRI stir sequence, which is showing hyperintense signals in the proximal tibia, tibial epiphysis and metaphysis with a central area of low signal and REM hyperintense signal. And there is also some high signal noted in the medial aspect, in the ligaments, in the medial collateral ligament, and along the distal end of the femur. So, sir, does the patient have fever? Hello? Hello? Sir, can you hear me? Oh, okay, thank you. But I can't hear, sir.
Yes. What do you want?
Sorry, sir. Sir, I wanted to know if the patient has fever.
Yes, fever.
Okay.
But is this can change your opinion? Yep. Leave. Go through the images. This is the images. I
Okay.
think all of them are static. What's your diagnosis, doctor?
Okay. Sir, it looks like an infective pathology
Mm-hmm.
with high signal. It can be Brody's abscess.
Okay.
Yes, sir. And there is extension into the soft tissues with some fluid along the distal end of the femur as well. The next step would be referring to. Sir, what is the age? Sorry, I forgot.
What is the name of this sign, doctor?
Sir, the penumbra sign.
Excellent. What is your management, doctor?
Sir, if it's a child, then refer to the pediatric ortho department, and this should be urgently treated as an infection, as it can affect the joint um, with IV antibiotics and drainage.
Okay. At which stage of osteomyelitis is this Brody abscess?
Stage of so this is high on stir sequence. And sir, can I see post contrast, please?
See, is this acute, subacute, chronic osteomyelitis?
Sir, I think it is on post contrast. It looks low centrally and peripherally it's high. Sir, I think it is subacute.
Subacute or chronic? Thank you so much, doctor. This is a Brody abscess.
Thank you, sir.
And we saw in T1 the penumbra sign. Next candidate.
Starting, sir. Please.
Islam, request control, please.
Yes. Yes, sir.
70-year-old patient presented with abdominal pain. Go on.
So, may I see coronal axial images?
Raise your voice, please, doctor.
Okay, sir. Sir, may I see axial images, or I can comment on coronal image?
As you like.
Sir, axial images. Oh, sir. Sir, I'm provided with the CT abdomen and chest of an adult patient with chronic pain. To scroll from top to bottom. So this is the male patient. Sir, I can appreciate my dilatation of common bile duct, but okay, sir. Sir, in this image, I can appreciate there is a dilatation of the lower esophagus and gastroesophageal junction appears to be dilated.
Yes.
And sir, this is resulting narrowing and luminal narrowing, which leads to some distension of the lower esophagus. It's mild fat staining also. It's a contrast. So apart from this, I want to look for lymph nodes.
So what's your diagnosis, doctor?
Sir, in this images and regarding the age of the patient, I'm suspicious for neoplastic etiology.
Okay.
But
What is
sir,
Which neoplasm?
Sir, usually the lower esophagus is usually adenocarcinoma. Sir, there in the upper one are squamous. So this,
What is your next
yes, sir.
step?
Sir, the next step, I would image all the sequences to look for chest nodules or chest metastatic lesion as well as bone window. And the next would be endoscopic biopsy of this lesion.
What else?
So may I see the lung window?
I think no lung window. Yeah.
Okay. So apart from this, I want to look at the nodal involvement as well as its
Okay, doctor. That is enough. Thank you so much. Leave the mouth. It was a case of cardia or gastroesophageal junction carcinoma. Look here, my colleague. Look here. When the examiner give you a sequence from the beginning, don't change. First
Okay.
examine it. This is for you. First examine and then ask for others. See, my colleagues, this is a carcinoma of the cardia and the gastroesophageal junction. Next candidate.
Yes, doc.
Welcome. Request control.
Okay.
60-year-old patient presented with pain, abdominal pain, and dyspepsia. Go on.
Okay. I've been provided with a frontal radiograph of a mature skeletally patient for abdomen and upper pelvis. Just I will have a look and then I will comment.
Okay.
Okay, I couldn't see that there is evidence of bowel loop dilatation. Okay, I can see that there is maybe okay, no, the bone window the vertebra appearing normal apart from its spondylitic changes.
What else?
Just I can see that there is okay, maybe there is a soft tissue density noted within the right lower quadrant of the abdomen.
Excellent. Excellent.
Which is displacing the intestine bowel loop to the left side.
Excellent.
But I couldn't see any evidence of calcification within. Just in this case, I want to look for it in the CT portovenous phase with contrast. Okay, just 1 second. Okay, I will have a look on the CT and then I will comment.
Okay.
Okay, this is the axial cut CT for the same patient. I can see that there is evidence of large soft tissue density with just I will go back to look for from the beginning and then I will comment. Okay, while I am going scrolling down, the liver and the spleen appearing normal. But I can see that there is evidence of marked right hydronephrosis noted within the kidney. Mostly, it's the ureter is compressed by the mass that I can see in the lower quadrant. In the lower quadrant, I can see that there is a marked fluid density well defined, noted related to the mass lesion, which noted within the right lower quadrant. The mass lesion show contrast enhancement and internal hypodensity, suggesting that there is maybe necrosis within. Just I want to look for the origin of this mass to oh, sorry, this is a coronal view. Okay, the mass is the kidney appearing normal, but the mass is appearing in it looks like it's coming from the
s- I want to say maybe this fluid density is uh, I'm thinking about something related to the appendix here, maybe appendicocele with appendical mass. Sorry?
Are you sure?
To be honest, no, I'm not sure because I couldn't see that there is evidence of any intestinal obstruction. This could be
this mass is aggressive or not aggressive?
it appears to be aggressive because of the contrast
Okay.
enhancement and the central necrosis within. So it could be also a retroperitoneal mass.
Okay. Give a possibilities. What is the possibility in this region? You told the kidney this mass is not didn't originate from the kidney. Okay. What else?
Yes. In this right iliac fossa, I'm thinking about the appendix, appendical mass with. I'm thinking about adenocarcinoma in the cecum or in the ascending colon. I'm
Excellent.
thinking of.
Okay.
Continue. Okay. Just however, if this is from the ascending colon adenocarcinoma, there is no evidence of intestinal obstruction, but I want to look for the mesenteric lymph node, and if there is any okay, I would look for the mesenteric lymph node. Yes, there is evidence of some mesenteric lymph nodes noted related to the aorta. But this mass also is displacing the aorta and the IVC.
Okay. What is your next step, doctor?
My next step would be CT staging for this patient, and I've looking already for the liver. There is no mets yet, so we need to do CT staging for this patient, chest, abdomen, and pelvis.
Is this tumor operable or resectable or non-resectable?
I think it's not resectable because it has a large abutting the great vessels, but it's not invading the vessels. Not yet invading the vessels, so it could be resectable. But the main, also the urgent thing that I would convey this also for the GIT
look here.
team.
One sec. Look here.
Okay.
What is this?
This is IVC.
No. Look here. Follow this. Follow the ureter. This is the IVC. See. This is leave the mouse. Leave the mouse.
Okay.
This is the IVC. But
yes.
Look here. What is this?
There is multiple myths within the ureter or something.
Again. Okay. Why they did this delayed? To assess the ureter. See, look at the ureter here.
Yes.
Look the ureter. The lesion completely infiltrate
the right ureter.
Okay, so this is very difficult. I didn't know the surgical details, but at least you should tell the examiner, doctor, it is infiltrate the ureter. Okay? Why? Because you detect marked hydronephrosis.
Yes.
Because we detect
maybe it's compressed only, completely compressed by the
No. How come? This is malignant mass didn't joke. Okay? Infiltration. Okay? So this mass infiltrate the ureter. And look here, it is abutting the aorta. Okay? The degree بقى. We should talk about the degree.
It mostly would be stage 4 because it's infiltrating other organs. So it would be unresectable.
Dr. Khan said that in the chest, if any malignancy abutting the aorta for more than 90 degrees, it is likely infiltrate the aorta, or it is irresectable. In the abdomen, it should be more than 180
180?
No, 180. 180
yes.
in the abdomen.
180, yes. Okay.
Okay, 180. 180. Okay, so see, I think here it is more than 180, 180.
Okay.
Okay, but at least if you told the examiner about these all details, okay, he will be very happy.
Okay.
Even if you didn't tell him, doctor, this is 180, this is resectable or an opera like this, but at least you know that we should assess the relation to the aorta
Blood vessels.
and
Okay.
to the IVC and to the Reuter. Okay.
Okay.
Thank you, doctor, so much. It was a large ascending colon malignancy mimic RCC. Okay, my colleague. From the first look, all of us can be confused. Is this RCC or something else? But here, see, most of the kidney here is good. I think this related to the tumor itself. See, related because see, there are a claw sign, the tumor completely surrounding to this cyst. Besides that, this is not just a cyst. It has many solid enhanced components. Anyway, thank you so much, doctor.
Thank
Next
you.
candidate. Next candidate. Hello? Hello?
Sir, I'm 50. Okay.
Yes.
Hello, sir. Yes, sir.
Welcome. Request control.
Okay, sir.
See, my colleagues, our practical session, what is the significance of it? To exchange our experience with each other. And this is the dilemma, and this is the most challenging part of the Viva and RCR. He examines you as a consultant. He wanted to investigate your skills. When you meet one malignancy, you will just enumerate your theoretical knowledge, or you will smudge the case, squeeze the case. You will try to get the maximum details, especially clinically related and surgically related details to make the maximum benefit for the patient. Why? I think Dr. Khan before show us one case, the rupture diaphragm didn't pick up in the first and the second day. And then the patient get in a very bad situation. His condition become very worse. But frankly, there were very subtle finding in the CT. The diaphragm was just little bit irregular. So all of these are skills. Doctor, this patient has abdominal pain. Go on.
This is the contrast enhanced CT scan of the abdomen of a patient with pain. There is evidence of hypodense lesion in the abdomen surrounding the aorta and its branches, elevating the renal vein, anteriorly, anteriorly displacing the left renal vein. I would like to see the, I can scroll, okay. Okay. I will first try to scroll from above down. There is evidence of multiple mediastinal lymph nodes, the right paratracheal, subcarinal lymph nodes, and multiple non-enhancing lesions in the liver, which is appearing continuous with the collection of hypodense lesion seen in the mid-abdomen. So I'm suspecting a rupture of one of the lesion in the liver. Or
again, doctor, again, what is this?
Okay, so mass lesion. Okay, so mass lesion infiltrating into the liver.
Okay.
Okay, it appears to be
Where is, see, doctor, one second. See, try to build your diagnosis step by step.
Mm.
Where is the center of this mass?
in
Is
the
it, yes, correct.
infiltrating into the liver, and
No, before infiltrating the liver, where is the center of this mass? Is this retroperitoneal, intraperitoneal? The center, the main center.
center is in the retroperitoneal region.
Okay, look at the vessel. What is the affection of this mass to the vessels?
It is engaging the vessel, suggesting a
Okay.
lymph nodal mass.
Suggested what?
Lymph nodal mass or lymphoma.
Okay, but look here. Look here. Is this the floating aorta sign?
Aorta.
The aorta is still adherent to the vertebral column.
Yes, not
You are correct, but by the way, but we are trying to get a more definite diagnosis. This is a retroperitoneal mass surrounding the aorta, but the aorta is not floating, not sandwiched.
Engaging the aorta, but aortic branches are engaged.
Okay, what else?
With the multiple liver lesions.
No. See, this is the extension of the mass. I see.
Through the liver and okay.
Not through the liver. This is just through the porta hepatis, widening of the porta
extending
hepatis.
Mass is extending into the porta hepatis.
Yes. Look here, doctor. Doctor, look at this slice. What happened?
It's extending up to the diaphragm, into the pata. Okay.
Look at the lower here. What happened? There are any connection of this mass to another?
Extending into the spinal canal.
Excellent. So what is your concern?
Yeah.
See
Okay.
See here. See here.
Yes. Yes. Significantly extending into the spinal canal. Okay. So this could be a mass lesion arising from the organ of Zuckerkandl. I would like to know the age of the patient.
Unknown age. Unknown age. What is your concern here?
It could be a neurogenic tumor.
Excellent. Excellent. Neurogenic tumor. Okay. Which type of neurogenic tumor? What is that? No.
Neuroblastoma.
No.
Okay.
Can neuroblastoma connected to the spinal canal like this at multi-level? See? Multi-level? What is the name? See, doctor. One second. What is the name of this sign here? Or here, what is this? What is the most common neurological nerve sheath tumor?
Neurofibromatosis with the plexiform neurofibroma.
Plexiform neurofibromatosis. What is your next step?
Like to see for other areas of involvement of the neurofibromatosis type 1.
Okay, like what? See here. See, even it is affected the posterior mediastinum. See? Okay, see, even up to the neck. Thank you, doctor, so much. It was a very difficult case. Okay, but when you give a differential diagnosis, try to give many, especially in borderline or confusing case. You tell very well, you were doing very well until you told this is a lymphoma. Very well. What else? Lymphoma should push the aorta anteriorly and giving the floating aorta sign or sandwiching sign. But here, the aorta is still adherent to the vertebral column. And plus that, see, there are a connection I show you to the spinal canal. See, this is the psoas, but the hypoechoic lesion, see, very obvious connection. And the mass is nearly non-enhancing. So we should thinking about neurofibromatosis. And what else? In my opinion, lymphoma, neurofibromatosis, and lymphatic malformation. But this is a solid mass. Okay? The three possible differential diagnosis. This is a solid, not cystic. What else? We should do the workup that we all of us know about the neurofibromatosis. Thank you, doctor, so much. Very rare case, but very difficult also. Thank you so much. Next candidate.
السلام
Hello.
عليكم.
Alaikum salam. Could you request control, please?
I can't. I don't have laptop.
Okay, 2-year-old female patient presented with left eye mass.
Okay, so I'm presented with a CT scan, axial cuts, soft tissue window of a 2 years old child
Doctor,
presented with eye mass. Yeah.
by the way, this is a very good case. If you pick up
Oh,
this case, I expect it for you. You will pass Viva. Okay?
inshallah, hopefully. Okay, come on.
Yeah.
Okay, so I would like to have a general look before starting my comments. So this is the CT brain showing multiple abnormal soft tissue masses
Yes.
that are hyperdense, associated
Yes.
with adjacent bone, يعني extensive periosteal reaction of the skull bones. It
What is the
involves
name?
the regions.
What is the name? What is the name of this
This
reaction?
is sunburst,
Okay.
mainly at the regions of the sutures.
Okay.
So these are multiple destructive soft tissue
Yes.
masses.
Okay. So,
Multiple
before we continue, what is your differential diagnosis
Okay,
till
first
now?
differential for multiple bone lesions are metastasis. Given the
What?
age, I would
Excellent.
suggest neurofibroma. I mean neuroblastoma.
Excellent.
Blastoma.
Excellent. Go on.
So
Then we'll
yes.
go on. Tell me what
Okay,
happened.
the eye shows the left eye is replaced by a large heterogeneous soft tissue mass that is extending towards the exophthalmos, associated with multiple calcification.
What's your diagnosis?
This could be retinoblastoma.
Excellent. What else?
Okay, other differential for such lesion
No differential, doctor. No differential
Okay.
here.
Okay,
What
fine.
else? You are
The other eye, the right
Yes.
eye, shows
Yes.
abnormal high signal intensity or calcification.
So
Again, suggestive of an bilateral retinoblastoma.
excellent.
So I would like to look for the trilateral and quadrilateral
Excellent, doctor.
retinoblastoma.
Amazing. Really amazing. Correct.
So I will be looking at the pineal region to complete the findings, which I couldn't pick any other intracranial marker.
So, doctor,
Okay.
if I ask you, what is the most important sign in retinoblastoma?
The most important sign.
See,
Okay.
I will help you. Child with eye mass, okay? And the child is
Okay.
younger age, 2 to 3 years old. What is the most striking abnormality you should find to be sure this is a retinoblastoma? Only one thing.
Calcification
Excellent.
in the retina.
Excellent. Thank you, doctor, so much. This
Okay,
is
thank you.
welcome. This is a very good case because why? There are a large يعني incredible masses, malignant masses here. The first thing come in our mind is neuroblastoma. Then there are bilateral retinoblastoma due to this calcification. If you didn't see this calcification, you should include neuroblastoma metastasis. Neuroblastoma, yes, because it is very huge and involving the bone. The doctor, our doctor, did very well when she asked for to rule out the pineal region, any associated pinealoblastoma, which is called trilateral retinoblastoma. Thank you, doctor, so much. Doctor, last question, please.
Yes.
What is which group, cancer group or tumors group, this retinoblastoma related?
Neuroendocrine tumors.
No. طب to which group the
DNET.
Yes, DNET.
DNET.
What is
Yes.
the DNET? DNET or BNET? DNET. BNET. Primitive
أيوة.
neuroendocrine tumor.
Endocrine. Yes.
So BNET, primitive neuroendocrine tumor. طب what is the DNET, my doctor?
The P.
DNET.
Yes, DNET refers to. I used to know it before.
This embryoplastic neuroepithelial tumor. No problem, but just by the way, to remember our colleagues, thank you so much. You did very well.
Thank you. Thank you.
Welcome. Next candidate.
Hi there. Hi, Dr. Ami.
Hi, Dr. Anthony.
Hi.
When your exam, Dr. Anthony?
I'm doing the exam in June, so tomorrow is the written and the.
Okay, so we must now help you too much.
Okay.
The most important is tomorrow, not today.
Yeah.
Okay, Dr. Anthony. Dr. Anthony, this is a 60-year-old female patient. Okay. One advice for you, Dr. Anthony, for tomorrow and for all colleagues. In long reporting, at least one case, he must bring a very important side finding. I will give you an example. In my Viva, it was a chest case, and it has a very important pathology. But in the upper abdominal cuts, there were organoaxial volvulus of the stomach. See, how could you imagine? And it was very important. In another Viva, the similar was he gave you a chest examination, and there were a very subtle pneumoperitoneum like this. So take care. The most tricky exam is the long sometimes. Okay, my colleague. But by the way, it is very obvious. And you don't be afraid. It is very obvious. But he assess your searching style. Yeah, let's start. 6-year-old female patient presented with abdominal pain and palpable mass.
Perfect. Thank you. I requested control. Yeah.
Yes. Go on through 1 second to the post contrast. Leave the mouse. Leave the mouse. Yeah, go on.
Yep. So I'm just going to have a quick scroll of the images. I'm scrolling from top to bottom. And I can see that these are contrast enhanced, both oral and IV contrast enhanced images of the abdomen and pelvis. Just taking a look at the entire sequences, and then I'll just come back to the abnormality in question. So this was a 60-year-old female who's presented with abdominal pain with a palpable mass, and I can see that there is a gross abnormality centered in the pelvis. It is large heterogeneous with areas of hypoattenuation and heterogeneous enhancement. There appears to be no connection with the adjacent bowel loops, no evidence of small or large bowel obstruction. It is centered predominantly in what appears to be the uterus / cervix, but no extension anteriorly to the bladder and no evidence of any extension posteriorly to the rectum, although rectal is fecal loaded. I'm just looking at the kidneys to make sure that there's no hydronephrosis.
Excellent. Excellent.
Yeah, the kidneys are normal. There's no evidence of hydronephrosis or dilatation
Mhm.
of the renal pelvis. I'm just going to look at everything else, just very quickly, looking for any air under the diaphragm, and just looking for any other vascular compromise, which there isn't in this case. So in summary, there is a large mass lesion centered within the uterus, with possible extension to the cervix.
1 second. 1 second.
Yeah.
Where is the uterus?
The uterus is, just going to make sure. So there's bladder, rectum.
Yeah.
This is your vagina, cervix, and then uterus would be in this region.
You can
here.
ask, doctor, you can ask for other sequence like this.
Yep. Yes.
Look
Likely.
here. Where is the uterus?
Okay. Perfect. So this the uterus would be inferior to the mass.
Okay. Again to the axial. Leave the mouse.
Yeah.
Okay. Check, please. Could you check both ovaries, please? Could you detect them?
Yeah, so I can see that both ovaries appear relatively enlarged. I'm not sure if this is the kissing ovary sign.
What happened
Okay.
here? What happened?
Yeah, so I see that
At least tell me, where is the pathology? At least where? In the uterus or in the ovary, on the ovaries?
I'm just going to make sure. I think the pathology actually is centered in the ovaries.
Okay,
because,
this is great. What happened, ba? Concentrate in the mass itself. What happened? Describe.
There seems to be focal areas of calcification,
and
low attenuation, and possible rupture or bleeding seen within the ovaries.
1 second. 1 second. This is cystic, and this is
soft tissue.
Okay, so what do you think?
Could be a dermoid, ruptured dermoid.
1 second. Doctor, again. Both ovaries are involved by complex mass lesion, solid cystic, correct?
Yes.
Where is the fat here? Could you detect any fat?
No fat is detected on this sequence, no.
Give me a possibility. Differential diagnosis.
Cystadenocarcinoma.
Excellent. Okay, excellent. Of which ovary or both ovaries?
From this, I cannot tell which ovary, but likely both.
Okay. What should you rule out in this case?
Any kind of associated appendiceal or mucinous deposits elsewhere.
Okay. What else?
Any kind of compromise to the adjacent structures. I'm just making sure.
Okay. What is the commonest route of metastasis in cystadenocarcinoma of the ovaries?
Would it be so I know the lymph nodal spread, then para-aortic, and then going into ovaries.
Okay, other than the lymph node.
Okay, it will be adjacent structures, so the kind of peritoneum and the omentum.
Yes.
But I can't see any kind of mental caking or peritoneal deposits. I'm not sure if it was. Can I just have a quick look?
So this is normal. Don't worry. Thank you so much, doctor. This is a pelvic mass, complex mass. Okay, compressing and inseparable from the uterus. At least ask for the other planes. Ask for the other planes to detect the site. Is this from the ovaries? See the vessels or the uterus. The uterus is completely separated or not separated, demarcated in the sagittal.
It's separated. Yeah.
No, not separated. It is inseparable. But we can see the uterus.
Yeah.
But look here, where is the ovaries? How can we detect the ovaries? Just medial to the vessels. The internal or the iliac vessels. See? This is the vessels. This is the vessel. and the mass completely abutting the vessels. So this is from ovarian origin. Second point, we should mention that the vessels are indented. This is very important surgical detail in both sides. The most strange about this case is a bilateral cystadenocarcinoma in the ovaries. Thank you, doctor, so much.
Thank you.
Next candidate. Do we have any other candidate? Dr. Mariam?
Yes, there are two more, but I'm not sure if they are available. I'm checking.
Okay.
Dr. Salma, are you there?
خلاص, no problem.
Okay, no one.
Did you take a chance, Dr. Mariam?
Yes, I did.
Take another chance.
Okay.
It is my colleague. For anyone who will organize, he must take more than one chance because Dr. Mariam and the other coordinator are doing a lot of effort.
If there is any chance, can I have a chance in the end? Because technical I cut at the end.
Yeah, I think you are candidate one?
Yes.
Yeah, okay, after Dr. Mariam with pressure.
Okay, thank you.
50-year-old female patient presented with abdominal pain. Patient has a history of a surgery.
Okay. This is a CT chest in the arterial phase. I can see,
Chest
CT
or
abdomen in the CT abdomen in the arterial phase. I can see that there are peripherally enhancing lesions
Excellent.
in the liver parenchyma, including the caudate lobe.
Yes. Yes. What do you want? What she say?
I would like to see it in the venous and delayed phases.
This is the venous.
Okay, there is a peripheral nodular enhancement with central filling in at the lesions, and the pattern goes with with hemangioma. But I would like to, yes, in the delayed phase there is complete filling in of the multiple lesions. So these findings suggest multiple hemangiomas.
What is the name of this sign?
Centripetal filling.
Okay, it has another name.
Another name.
Closing iris sign. Closing iris sign.
Closing iris sign. Okay.
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 What is your next step, doctor?
These hemangiomas are benign, but because of the size of the hemangioma, I would like to advise for the follow-up. But as this is a case for previous surgery, I'm not sure previously there was any history of malignancy or not. If needed, further MRI abdomen.
Okay, thank you, doctor, so much. It was a case of multiple hemangioma. See here, my colleagues, my advice to you here, in arterial, it should be nodular, peripheral, discontinuous. Discontinuous. Why? This is a very important differential point to other hyper-enhancing lesion, besides the closing iris sign. Okay, because there are some atypical HCC. There are, as I think, about 7 or 5 or 7 rare types of HCC are very confusing, like HCC mixed with cholangiocarcinoma, HCC containing fat, Skerras type of HCC. Many types are confusing. Here in the hemangioma, it should be nodular, peripheral, and discontinuous. See here, discontinuous. Doctor, hemangioma, pathologically related to which category? Is this a tumor or a vascular malformation?
This is a vascular malformation.
No, hemangioma is a tumor. What is the difference between a tumor and a vascular malformation?
The tumor will involve the hepatic parenchyma.
And also the vascular malformation will involve. No, pathologically.
Okay.
Pathological. What is the difference? A vascular malformation is normal tissue in abnormal location.
Right.
Okay? Why? There are a vein and the nidus and the artery. All of these are normal. But
Right.
tumors are a tumor cell containing benign, locally malignant, and malignant. There are the three types of hemangioma. There are a benign hemangioma, and the locally benign hemangioma, and the malignant hemangioma. I will remember you with Kaposi sarcoma. Kaposi sarcoma is a type of, I don't know if this is locally malignant or malignant. Anyway, but it is aggressive hemangioma, Kaposi sarcoma. Okay, my colleagues, this is very important. I think before, but in this group, I give some bits about how the different pathological type of hemangioma. But at least you should know the hemangioma is a tumor, not a vascular malformation. Second point, because the size here is large. What is the cut point size, doctor, we should worry about? Hello?
Yes, a 5 centimeter?
Yes, yani 4 to 5 because it is of high risk of hemorrhage. So it should refer to the GIT team. Thank you, doctor, so much. Next candidate number 1.
Yes, my dear, thank you.
Welcome, doctor. This 8-year-old female male patient presented with epigastric pain.
I'm trying to scroll now. I'm presented by CT scan of the abdomen in this elderly patient. This is post-oral contrast, but the first sequence is devoid of IV contrast. I'm scrolling from up cut to down cut to see my comment.
Yes.
There is lobulation of the liver surface. There are some surgical clips in the liver, may be attributed to cholecystectomy clips.
Okay.
And another abnormality is huge distension of the stomach. And some intestinal loops are also distended beneath the stomach with air in the wall, pneumatosis intestinalis in the wall itself. In my usual practice also, I will change to a lung window to see if there is free air inside or not. The peritoneum, I mean pneumoperitoneum. So the abnormality here is the presence of multiple dilated bowel loops.
Mm-hmm.
It's not scrolling with me. Can you scroll for me, please?
Okay, 1 second.
So the abnormality present is multiple dilated bowel loops centered in the center of the abdomen, mostly attributed to jejunal loops with pneumo.
1 second.
Pneumatosis intestinalis as
doctor,
well.
Yes, pneumatosis intestinalis. Where is this loops? Where is the exact location?
I think it is in the root of the mesentery itself, the jejunal loops.
What is this, doctor? What is this?
This is the stomach.
Okay, what is this sac?
This is the lesser sac.
Okay, so the loops. Where the loops? Dilated loops in the lesser sac. What do you think about?
I would think about internal hernia.
Okay, so see here.
So maybe vascular compromise, and as a consequence, there is some infarction or vascular compromise of these loops.
Excellent.
And infarcted and pneumatosis intestinalis as a consequence.
Excellent. See, this is the afferent limb or afferent loop, and I think here we should look for the other 2 point of transition. At least, thank you, doctor, so much. This is the type of internal hernia, Why? There are a cluster of dilated lobe associated with nematosis intestinalis and nearly very markedly hypoenhancing, markedly, okay,
Yeah.
within the lesser sac. First possibility, internal hernia until proof otherwise. Even if
But
you
but
detect, يعني, like here,
but
I
the
detect only
but the,
one limb. Yes.
but the stomach position is normal or there is malrotation?
See here, it is just shifted little bit. Stomach is normal. What happened for the stomach? Because also this is, see the pylorus is here. This is the pylorus, and this is the cardia should be up. At least there are no any mesenteric coaxial volvulus. Okay, but I think the stomach is normal. Look here, is normal. Just the stomach shifted upward and laterally by this cluster. My colleague, another tip. When you see a cluster of ectopic dilated bowel, okay, in ectopic location, think about internal hernia. Okay, my colleagues, thank
So
you for,
this
yes.
type is paraduodenal.
No, this is lesser sac.
Lesser
No,
sac.
see, lesser sac. Where is the paraduodenal? This is the duodenum. Where is the duodenum? See, by the way, this is afferent loop. See? Okay.
This is
The
through
para
the window of Winslow.
Winslow, yes.
Yeah.
What is the window of Winslow? It is a foramen between a lesser and a lesser sac and the greater sac.
Yeah.
See, my colleagues, in the paraduodenal is another entity. This study is not a complete study. I don't know why.
So this is an
Anyway,
urgency. I refer to the surgical team emergency.
yes. At least, see, my colleagues, this is an internal hernia. Where is the center in the lesser sac? Okay. At least you should tell the examiner this. Okay, my colleagues.